Yeah, and next I want to introduce Kyoko Hono Matsui. She's going to talk about first-line therapy for myopic tractional maculopathy, vitrectomy.
Thank you very much for giving me a chance to speak. May I have my slide? Not this one. Yeah, yes, this one. Okay, first-line therapy for myopic tractional maculopathy, vitrectomy. And the primary factors contributing to tractional maculopathy are axial elongation, posterior staphloma, and stiffness of ILM and vitreous traction. And macular buckling without vitrectomy addresses the four main causes differently. It pushes the macula forward and shortening the axial length, and it's said to improve staphloma. However, ILM stiffness and vitreous traction remain unaffected. In contrast, vitrectomy does not change axial length or staphloma, but removes the ILM and relieves the vitreous traction. Let's examine these four factors one by one. Axial elongation primarily occurs in the equatorial region and does not significantly alter the curvature of the posterior part of the eye. This is why vision can still be corrected effectively with glasses. And next, staphloma. Staphloma often encompasses a wide area of the fundus. So the macular buckle does not treat the entire staphloma, but rather creates a small elevation within the staphloma. And sometimes a generalized bowing of the scleral curvature is mistaken for a staphloma. A staphloma is characterized by an outpouching of a limited area with distinct edges. So wide field OCT is essential for accurately identifying these edges, and 6 mm scans does not show staplomas. Next, stiffness of the ILM and vitreous traction. While 6 mm scans provide information only around the macula, wide-field OCT images reveal the full extent of retinoschisis and its underlying causes. In this patient, the staphloma edge is seen here with the inner and outer retinoschisis confined to the staphylomatous area, suggesting that staphloma significantly contributes to tractional maculopathy development in this patient. But wide-field OCT is highly useful, but cross-sectional images alone may not fully reveal the root cause of tractional maculopathy. In this patient with retinoschisis, a horizontal OCT image shows posterior vitreous detachment from the inner retinal surface within the staphylomatous area, along with vitreous adhesion to the fovea. So based on this image alone, one might conclude that the retinoschisis of this patient is caused by foveal traction. But an oblique OCT image reveals 3 lifted retinal vessels with posterior vitreous adhering to the inner retinal surface at the sites of retinal vessels, and multi-layered schisis surround the vessels, and outer schisis extends toward the fovea from these vessels. This vascular traction may be missed in conventional 6 mm scans. Radial scans from wide-field OCT highlight vitreous traction on retinal vessels in the patients with retinoschisis. And using 6 mm scans, Shimada reported that paravascular lamellar holes were present in 83% of the eyes with retinoschisis, with outer schisis extending from retinal vessels to the macula. This underscores the importance of retinal vessel traction, suggesting that while retinoschisis is macular, its origin often lies away from the macula near retinal vessels. And macular buckling has risks of developing macular atrophy over time, and the procedure also carries a risk of injuring penetrating vessels. Numerous branches of posterior ciliary arteries penetrate the sclera in the macular area. Furthermore, approximately a quarter of highly myopic eyes feature a macular vortex vein, which is also susceptible to injury by macular buckling. And finally, macular buckling may exacerbate mechanical damage to the optic nerve. This is analogous to pressing a balloon with fingers. When one area is compressed, surrounding regions bulge outward more prominently. And in this left figure by Dr. Bolters, you can observe how the scleral curvature of the nasal sclera is significantly altered, and it affects the optic nerve damage. And when the surrounding area bulges posteriorly, this expansion encompasses the optic nerve region. And optic nerve damage is a major cause of visual impairment in high myopia, yet it is often overlooked until its terminal stage. This 60-year-old woman was misdiagnosed with macular atrophy, and by the time she was referred, her visual field was severely compromised. She was barely able to walk. Optic nerve damage develops earlier than in non-highly myopic glaucoma, risking complete vision loss during productive years. So no more further damage on the optic nerves is important. So to sum up, wide field OCT often reveals that vitreostructure of retinal vessels away from the macula is a primary cause of retinal schisis. By addressing destruction internally, it can be effectively released, treating retinal schisis. A less invasive vitrectomy is recommended to avoid unnecessary mechanical damage to the choroid penetrating vessels and the optic nerve. So let's yes for vitrectomy. Thank you so much.